have with us Nick Rolnick, a physical therapist from the US and one of the world's leading authorities on blood flow restriction, aka BFR, the subject of today's podcast. Nick, why don't you give us a little 2-minute introduction to yourself, and we'll just get straight into it.
So I've always been interested in optimizing performance, and I've always been interested in exercise, and I found physical therapy actually through my mom's recommendation, and I've never really honestly looked back. I love that I can get somebody from rehab to performance, and that mission has kind of evolved now that I've taken on the mantle of the human performance mechanic and the BFR pros. And our mission as the human performance mechanic and the BFR pros is really just getting people back to the activities that they love as quickly as possible using the most current evidence-based modalities. And that's that ultimately they can experience the joy of pain-free movement, because that's what it's really all about. People want to move pain-free. They want to get back to activities that they love. And ultimately with accomplishing both of those missions, that we can make this world a little bit healthier, happier, and better place to live. And that's kind of how I've fallen into BFR, because BFR is a modality that has actually been around for 50 plus years. It was invented actually in Japan by Dr. Yoshiaki Sato in 1966. And he called this innovative training method Katsu training, which means added pressure training. And ever since then, a lot of the research now has been coming out to support the amazing anecdotal stories that people have had about using blood flow restriction to help them get back to the activities that they love quicker than they ever thought possible, as well as helping individuals that we, prior to integrating BFR into our physical therapy plans of care, were not able to be as effective at helping. And in situations like post-surgical, where atrophy is a huge problem. And so now that blood flow restriction has almost reached mainstream as of early 2020, more and more research continues to be published to show its efficacy. And that's part of the reason why it's become so popular, is because unlike a lot of other modalities in physical therapy, BFR is one of those modalities that has a ton of evidence that supports its use. And now what I predict is that with the unique effects of BFR, we're going to start to see a lot more populations that can benefit from its use. So okay. It's really awesome that I get the opportunity to teach other physical therapists around the world how to integrate this awesome technology into their practice and, really change lives. And that's what helps me fulfill my mission of making this world a better place and getting people back to the activities that they love as quick as possible. So I'm living my dream, and I could not be more enthusiastic of the opportunities that I've been given so far. So thank you for having me on the podcast, and I hope to answer some questions and spark some conversations if anybody's listening that is involved in research to maybe try to go down the path of blood flow restriction.
No, again, thank you for your time. I appreciate you making time for us. So you've mentioned BFR there straight out the gate, obviously being one of the modalities. Can you tell us exactly what BFR is? So you mentioned it's, let's just say the origin of it going way back when, 50 plus years ago, but what exactly is BFR? Maybe you can describe what's actually happening for the listeners.
So blood flow restriction, or BFR, involves use of a cuff that's calibrated by technology, whether that's automatically via a computer or manually via an external Doppler. And what that does is allows us to carefully and safely restrict blood flow to the arm or the leg. And in doing so, that challenges the local energy metabolism such that you now have a reduction in oxygen locally. And what that does is accelerates the time needed in order to get a training effect, such that this artificial environment that you're creating by restricting oxygen, our muscle fibers don't know any different, right? They just know to contract and relax. And when energy is limited, then that will change the relative contributions of oxidative fibers and glycolytic fibers that tend to correspond to the type 1 and the type 2 fibers. So what ends up happening is, as a result of this accelerated fatigue, these metabolites accumulate, which would signal an increase in intensity of the exercise, such that we're getting earlier recruitment of the type 2 muscle fibers. That's huge, because in rehab, right, most of us, I would say 99% of us as physical therapists, tend to underdose our patients. We don't necessarily bring them to the intensities required in order to stimulate actual increases in muscle mass and strength. If you really look at the literature and you compare 3 sets of 10 for a 2 to 5 pound bicep curl to what's actually required to elicit muscle hypertrophy and muscle strength increases, we're not there. And blood flow restriction allows us to bring our patients to that level with lighter weights, such that we have people that can't lift heavy because of an injury, because of contraindications, what have you. And now with the BFR cuff on, we're able to stimulate an artificial high intensity environment for the muscle. And as such, we can help them recover their muscle mass quicker, or prevent muscle mass loss at all, with the strategic implementation of blood flow restriction into our plan of care. So that's where it's kind of taken its root from. And it's not just resistance training. So we manipulate the local physiology, and in an aerobic training capacity, because we have a reduction in local oxygen concentrations, because of the cuff restricts blood flow to the exercising limb. Now we challenge our local energy metabolism and mitochondrial efficiency and function. So we're able to increase our VO2 max, our aerobic capacity, with having people just walk or cycle on a treadmill, especially the deconditioned patients that we see that tend to be older, the geriatric patients. But the research has also shown that you can have this effect in healthy, very healthy individuals like collegiate athletes. There's a study by Park that was done that did that. There was also Ersprung in 2017. I believe that was looking at elite military athletes. So it's been done on a lot of different populations, which opens it up to both the rehabilitation and the performance setting. And that's kind of where I found myself at as a educator, but also a consultant for some of these high functioning athletes that want that 1% improvement. They're having trouble getting that, and BFR can help take them over the edge.
Okay, that's perfect. There's a couple things that I want to dive a little bit deeper into. With regards to the BFR itself, you mentioned that they are cuffs with specific pressures that you have to use. Can you talk to us a little bit more about that? Are there any particular parameters that you want to have, and what are the sort of contraindications? So I suppose what I'm getting at here is, what's to stop someone going to the gym, grabbing one of those elastic dyno bands and going, oh, this will work, right? I'll just, wrap that around my arm 3 times. That's pressure. I think what we hear a lot is, or what you see a lot is, people talk about pressure from a 7 out of 10 of pressure, and you're okay. Mm-hmm. So yeah, what pressure are you looking at?
I'd be lying if I stood here and said that putting a band on you won't work, because that's not true. If you alter the local environment of the muscle tissue, you are creating an environment that will accelerate fatigue. And when you accelerate fatigue and you contract your muscle, you're going to get earlier recruitment of the type 2 muscle fibers. You're going to reach volitional failure closer than if you had a free flow control. So you're not doing that. So I can't come up here and say that you can't do that.
Mm-hmm.
But what I can do and what I do is argue that as medical practitioners, we're held to a higher standard. And there is evidence to suggest that there is a sweet spot in pressure such that if you go too light, it actually doesn't change the metabolic environment in the tissues any more in relation to free flow, because our bodies are great at compensating. So our blood pressure, for example, might increase to change that, to overcome the pressure that we're applying by the tourniquet or the cuff. Likewise, too much pressure can do two things. The first thing is that for us, again, as medical providers, we don't want to exercise our patients in situations where we may create full occlusion, where we're having too much pressure to the point where there is zero arterial flow and zero venous return. And that's a situation that can happen when we're arbitrarily applying pressure, and I'll circle back to that if you remind me if I don't talk about it. But then secondly, 1A on that is that when we don't have any blood flow, right, and blood flow becomes stagnant, that increases our risk of adverse events unnecessarily. So we have stagnation of blood, and we don't want blood clots to occur. And that is one of the largest concerns with using an arbitrary system to assess pressure. Second, we know that the higher the applied pressure, the more perceived exertion and perceived pain that accompanies the exercise, along with relatively similar benefits. So if I'm going to have somebody in the rehab setting and I want them to just gain a benefit, well, I want to be as objective as possible, use the least amount of pressure possible to facilitate the adaptations that I want without having them undergo any sort of excessive amounts of pain and discomfort. Because BFR by itself is still really uncomfortable and a lot of people don't like it. So why would I make it harder on somebody than I need be? Getting back to the arbitrary pressure, there's actually, that was actually one of the what's called practical BFR, where you can wrap around straps, you can wrap around knee wraps, elastic bands, you name it. And there is evidence, again, to show that it does work, right? Like, no one's saying that it doesn't, but the patients that we see tend to have more comorbidities or more specialized circumstances, such that we need to be a little bit more careful and use our clinical reasoning to determine whether or not an individual is appropriate for BFR. And in doing so, as I said, we are held to a higher standard, so we should be using objective data, not subjective reporting. Now, Jeremy Len Aquis, who is one of the leading researchers in the world on blood flow restriction, actually was one of the researchers that first came out to support the use of blood flow restriction using practical knee wraps. But you can imagine that, and this is the example I give when people ask, is that, well, if I'm feeling good and I'm waking up and I'm like, oh, I'm ready to exercise, my perception of my reality is going to be a lot different than if I woke up on Sunday morning, hungover as all hell, and I'm perceiving my world a lot differently. So you're using a subjective marker as a surrogate for an objective, what should be an objective piece of information. And so Len Aquis Lab actually investigated last year does actually arbitrary pressure, so 7 out of 10 perceived pressure, does that actually give us reliable, reproducible, that's what I mean, reliable, reproducible results? And in fact, it doesn't. They had individuals come in once a day for 3 days, and they they used a pneumatic cuff because that was the only way that they can actually quantify the amount of occlusion, or at least pressure, that was their 7 out of 10. And they had them repeat that once a day for 3 days. And what they found was 20 to 25% under or overestimation of pressure in the arms and the legs over that 3 consecutive days. So meaning that my pressure could be as wide as 40 to 50% difference on a given day based on my subjective reporting. And we know from the research that you need about 40% of the amount of pressure required to completely restrict arterial flow and reduce and restrict venous flow. So BFR by definition is fully occluding venous outflow, so venous return, and partially restricting arterial flow. If you partially restrict arterial flow, that's when you're going to get the reduction in oxygen concentration most effectively, because you're now reducing the actual blood volume getting to that extremity. So yeah, I mean, it's one of those things that we just should be held to a little bit higher of a standard. And we know that in the arms, getting back to that, 40% of that value, that maximum occlusion value, tends to be the minimum amount of pressure in the arms that will actually elicit adaptations. Also out of Len Aquis Lab, counts, I think it was 2016, showed that the same amount of benefit from 40% to 90%. But again, as we know, 90% tends to increase the amount of discomfort and pain associated with application of BFR. So why would I want to go to 90% if I'm able to lift a percentage of the 1RM that actually makes sense, which is really between 20 and 40 to 50% of the 1RM? Why would I want to give more pressure than I need to get the same results if we're talking about muscle mass and strength here? And then in the legs, it's been shown at about 50 to 60% of the limb occlusion pressure tends to be what is the minimum pressure needed in the legs to actually change the environment of the tissue relative to a free flow condition. So there are minimum pressures. I don't necessarily think they're maximum, but I think we need to also be more cognizant of making sure that we're working within that sweet spot such that we're not making the exercise too easy for the client, but we're not also making it too hard, because BFR is challenging. So if you're not feeling the burn, like the motto here at the BFR Pros is chase the pump. Like if you're not getting a pump and you're not feeling that burn from that metabolite accumulation, you're really not you're not really gaining a benefit from the BFR exercise. So that, and then your second part was the contraindications.
Yep.
So BFR is it is a viable medical, but also fitness intervention, but we still need, just like anything, even exercise with some people are contraindicated. So we need to be aware of some of the large contraindications associated with blood flow restriction. And the largest one is prior history of a blood clot. Now we know based on the research that BFR actually doesn't increase risk of blood clots. It actually increases fibrolytic activity relative to high intensity training. So they're very similar. And that has to do with the reperfusion effect and the release of tissue plasma antigen and other factors that can help break up blood clots before they form. But it's one of those ideologies that kind of got adopted in a textbook, and now it's out there for absolute adoption. But I will say that I have performed BFR safely and successfully with individuals with a history of blood clots. I just ask for the physician clearance. That's really, sometimes people get a freak DVT, it happens, but that shouldn't automatically disqualify somebody, especially if you feel that they could really benefit from the addition of this in their plan of care, given what we know about the current evidence base.
Just to clarify there, when you say someone can have a freak DVT, you mean prior to training, not while they're training.
Yeah. So
That's what you
like,
mean,
for
right?
example, like somebody very active, I'll give you an example. One of the clients like was very active. She's a 72-year-old, but she had a DVT when she was 26 or 27. She got on a long flight. She had one in her calf and she was relatively healthy after that.
Yeah. Okay. Yeah. Just making sure for anyone listening, it's not that it occurred during the training. It's something that.
Yeah. So blood clots are the big one. And then we have other things that should make sense based on, when I teach the courses, it's all about understanding what's going on underneath the cuff and what's happening. Because if you do not understand what's happening from an exercise science, but also a cardiovascular and hemodynamic perspective, then you're not going to be able to most efficiently and effectively apply this modality. So we're restricting arterial flow and we're completely occluding venous flow. So what that means is it's significant stress to the arteriovenous system. So if you have any sort of arterial disease or venous disease, this is probably not a modality that you're going to want to include in your patient's plan of care. Certainly not without physician clearance, that's for sure. Big time active cancer, open wounds, distal to the cuff application. I mean, some of this stuff kind of, makes sense. I mean, there is a factor V gene that increases risk of blood clots. That is also a contraindication to BFR exercise. Pregnancy in some situations is a contraindication to exercise. Acute post-surgery. This is a really big topic when I go out and I give my workshops, because a lot of clinicians want absolutes. They want, I need to know when to do this at this time, with this given type of demographic. And unfortunately, right now in the research base, we do not have an absolute understanding of when you should integrate BFR into the plan of care in post-surgical clients. We do have a pretty extensive, now growing body of research on anterior cruciate ligament reconstruction. That tends to be the largest demographic that has BFR research. Also, we're getting more and more post-operative. I mean, knee scopes are also an area of research, but tends to be mostly that's the post-operative research. That is the majority. But again, there's other individuals that are using it successfully for Achilles, that are using it successfully for elbow. It really, unfortunately, what I tell people is they need to maintain an open dialogue with the referring physician. So if you think that BFR is important and could help with reducing atrophy, accelerating the healing process potentially with the high amounts of growth hormone and other effects of lifting really intensely and such the postoperative phases, then you just got to confer with your physician and get them on board. And if they have no idea what the hell BFR is, well, then that gives you an opportunity to come in and give an in-service. The biggest thing that I get told from surgeons when I go and speak with them is that they fear the physical therapist making a unilateral decision without their input one way or another. So I always make it a point to suggest that you need to, it's their baby, right? Their post-op, they went through their baby. So in situations post-op, it's really important to make sure we're referring, we're collaborating with the referring surgeon. And those are the big ones. And then we go through in the course, the workshop that I teach as well. And you can find plenty of research on these as well with safety about stratifying risk. So really important to understand what you can do to medically stratify somebody as a high, medium, or low risk client, but also how to program effectively to make sure you're maximizing whatever stimulus you are giving that patient or client in their respective medium, high, low risk categories. And so it's important that people understand, again, the physiology, because if you don't understand the physiology and what's going on, what happens when you apply continuous application, meaning the BFR cuff is on the entirety of the exercise, or it's inflated during the exercise, but deflated during the rest. These are all things that you should be aware of when you're applying BFR to your client, because then you can help with programming and periodizing an effective rehab plan to get them back to doing what they want to do as quickly as possible.
Okay. So you mentioned there right at the end, keeping the pressure on, keeping the pressure off, etc. What are the parameters that you would, let's just say in general, be working with someone in terms of time, sets, reps, resistance that they'd be using?
So there's a great article that was published last year by Patterson, Stephen Patterson, and 12 other of some of the top researchers in the world. They got together and they came up with a consensus of what the current evidence base says in the research, right? So that's another thing that's important to differentiate, is that just because it's in the research and they do it a certain way doesn't mean that that translates into clinical practice. That's really, really, really important because if anybody who's tried to get somebody to immediately do a 30% of their 1RM leg extension or leg press or squat, and on the first day, it's really, really, really difficult and almost unfeasible for that person. So there's a ramping up period associated with that. But in general, the cuffs can be anywhere from 5 centimeters to 17 centimeters in width, right? Too narrow, there's too much pressure on the underlying neurovasculature, and you're risking potential demyelination injury, potential ischemic injury due to the high pressure. Conversely, too wide of cuffs can actually interfere with the ability of your muscle to contract. And so there's evidence to suggest that wider cuffs, there may be a slight attenuation of hypertrophy underneath the cuff site. So using cuffs that, for me, I actually prefer a little bit narrower on the arms, a little bit wider on the legs, because it tends to just need less pressure on the arms, more pressure on the legs. But also the biceps tends to roll underneath the cuff for the arms, and the triceps, not so much, but really the biceps. So if you're doing a rowing exercise or whatever, too wide of a cuff tends to be a little bit uncomfortable. So that's the cuff width. And then pressure, recommended pressures for the arms tend to be 40 to 50% in the arms, and anywhere from 60 to 80%, but really I think it's closer to 50% in the legs, 80% in the maximum amount of pressure in the legs. So that means that there's always blood flow coming in to the limb. That's really important, and you need to standardize that either automatically or with an external Doppler. And then that's the actual application in terms of the pressure. The loading parameters, anywhere from 20% of the 1RM to 40 to 50% of the 1RM. Now, if you use a weight that's too light, it actually doesn't do much, even with the application of BFR, because the mechanical load is not high enough to actually elicit hypertrophy. So the minimum amount of load that we have currently right now to suggest that there is a hypertrophic benefit over low load exercise is about 15% of the 1RM, but that's suboptimal when you compare it to 20% or greater. So pretty much clinically, you want to get them into that loading zone as quick as possible. You also can work up to about 40 to 50% of the 1RM. That's been shown to have benefits. Anything above 50%, muscle activation tends to be high enough, and intramuscular occlusion happens naturally with anywhere from 20 to 30% of the 1RM. Intramuscular meaning that there's no blood flow that's getting to the muscle anyways. So you can replicate that BFR without the actual application of BFR, but you can't take any intra-repetition rest. So a lot of times people do a repetition and then just relax, like a bicep curl. You can't do that if you want to maximize the intramuscular hypoxia,
okay,
which tends to be the driver of BFR. So too heavy, no good, because muscle activation is already high. The weight's already high enough such that the speed of contraction is already slow enough that you're getting maximum mechanical tension on those activated muscle fibers to produce hypertrophy and strength gains. Too low, it's not enough external load in order to create any sort of adaptation. Then the repetition schemes tend to go two different types. The first type is 30 repetitions on the first set, followed by 3 sets of 15, which equates to 75 repetitions, each with 30 seconds of interset rest. Although I've used as much as 60 seconds of interset rest, and that's also been shown in the research. Or doing 2 to 4 sets to failure. And failure training has its pros. It also has its cons as well. So that's something that if there's interest, you can briefly hit upon there. But tends to be in the clinical population, you want to get them to the loading zone as quick as possible and do 30, 15, 15, 15 at the desired pressure that you feel like that they can handle. Tempo tends to be anywhere from 1 to 2 seconds for the concentric or eccentric. So you're looking at anywhere from 5 to 10 minutes under occlusion for any given exercise that you perform. And then you're going to deflate for a minute after. So you never want to keep the cuffs on when you're exercising for too long for your resistance training, at least, just due to the fact that the buildup of metabolites, how that can potentially interfere or interact with the local vasculature, as well as the muscle itself. So just making sure that you're deflating after the exercise can have additional benefits. We used to think, at least I used to think, that it might be better to chain exercise together and build up to a degree more time under hypoxia, which may have a role in stimulating arteriogenesis and bone formation. But from a hypertrophy perspective, it doesn't necessarily we don't necessarily need to do that because muscles are going to work a little bit different. So I do deflate after each exercise, each exercise bout. And I think that's pretty much it from the prescription side. You tend to do more isolated unilateral muscle groups, and then as you get more conditioned to the stress, you can add in more multi-joint exercises and play around with it. I've written up in an upcoming paper that should be published by the end of the year, at least. I've written up some ways to periodize and progress BFR training. So that should hopefully be published in a journal at some point. So there's more details that are going to be available shortly in a peer-reviewed format. But that's pretty much it for at least answer your question, I hope.
Yeah, absolutely. Pretty thorough there. So you've mentioned you use it for geriatric patients, and you've mentioned that it's the application for Postop is something that's currently being researched. What other populations are you currently using it for? And sort of 2, have you any anecdotal evidence that you can talk to us about from your own patients and the sort of wins that you've seen with them or the progress that they've made?
Oh yeah, I mean, and I'm just one example. There are hundreds, if not thousands, of clinicians, but also thousands of patients that have benefited from the use of BFR in their plan of care when other therapies have failed. For me, when I don't deal personally with a lot of post-ops because I have a cash practice at a network with my business model predominantly being word of mouth.
Yep.
So I don't necessarily have physician referrals. But I have seen some ACLs and I have seen some post-op individuals, but mostly I think the biggest home runs tend to be in the ACL populations and the knee osteoarthritis populations. And I'll talk briefly about both of those. In the ACL populations, there's really 3 limiters in an early plan of care. The first one is quadriceps muscle mass rapidly atrophies. The second is quadriceps strength rapidly decreases. And the third is postoperative pain is very common. You combine them in a triad and you take into consideration arthrogenic muscle inhibition, and you're dealing with a very potent stimulus for challenging rehab and recovery. And what blood flow restriction has been shown to do in these clients is actually performed just as well, if not superior, to the traditional heavy loading protocols that we want to get them to do in early rehab. So the best example of this would be one of my buddies who I actually met in person now, finally, a couple of months ago, Luke Hughes, for his PhD dissertation, did an excellent study comparing low load BFR, 30, 15, 15, 15 at 30% of the 1RM with a leg press machine compared to 3 sets of 10 at the estimated at 70% of the estimated 10 RM, right? So they just scaled the 1 RM and they had 30% of that. So that's traditional guidelines for increasing muscle mass and strength. And what they showed was similar improvements in muscle mass, similar improvements in muscle strength, but the joint swelling and the pain, both during, immediately after, and 24 hours after exercise with the BFR group, was superior to the heavy load group. And perceived function increased in a greater degree compared to the heavy loading group. And what that tells us is kind of mirroring what we as clinicians who have dealt with individuals that are recovering from ACL rehab have shown, in that there is significant pain relief in the application of BFR. Now, you're going to get higher degrees of muscle pain, but that's expected because the muscle is undergoing hypoxia and you're getting increases in anaerobic metabolism, which is forcing those metabolites to accumulate in the muscle. So that's normal. But what's cool is you're getting less joint pain and you're really not stressing the integrity of the joint either in terms of the actual surgery, which is super, super, super cool. So you have individuals early in rehab where they're atrophying really, really quickly. Well, you can now pair this with your Russian, for example, your neuromuscular e-stim, and now you've created even a more potent environment for staving off muscle atrophy and recruitment of quadriceps muscle strength. Really with BFR, you're not replacing anything that we're currently doing in our rehabilitation and our plans of care. You're just complementing it. So that's part of the reason why it's important to understand what is BFR and how can it be beneficial, because once you understand the principles, then you can start to apply it in the clinical setting. And it's really exciting, some of the results that we're seeing from a anecdotal, but also a research perspective. And then second, with NEOA, we know the evidence that suggests that moderate to heavy loading is superior to light loading in muscle mass, strength, function. But the issue becomes with them is the joint reactive forces that are going through the knee tend to be not well tolerated when you're exercising with them. So what BFR does, and there are now at least 4 studies on OA and the knee, is it can reduce the knee pain during the exercise and allow those individuals to obtain similar degrees of muscle mass and strength compared to the heavy load training. Now, Faraz in 2018 had a really good study that also showed kind of what we see in clinic, which is that of the individuals that were randomized to the heavy load group, 25% of that cohort actually dropped out due to knee pain. Which again illustrates that just because we have evidence to show that high intensity exercise is beneficial in the long term, clinically, we see that these people are not going to exercise if they dread actually exercising. And so those individuals that I work with that have NEOA related pain, I can get them underneath the BFR using BFR training. And all of a sudden now they're able to feel their quadriceps again. They're able to move and get that localized analgesia, which we see as well. I mean, Korakakis has 2 studies that look at the analgesic effects of BFR. Really it's fascinating to see. So those are really the home run populations. And then you get the deconditioned geriatric client walking. And I mean, Sentner in 2018 had a great systematic review that compared the differences between hypertrophy and strength on heavy load versus light load with BFR and showed similar increases in muscle mass and strength between the heavy load and the light load with BFR. Really nothing significant happening with the light loads that we're commonly using in rehab. But what's really cool about that paper was they showed that of all the papers that met the inclusion criteria for that meta analysis, that just getting individuals walking on the treadmill increased their hypertrophy by 3% and their strength by 13.3%. And so you're seeing these phenomenal results because we're now forcing muscles into an environment that they're not used to. And so we're getting that early recruitment of those type 2 muscle fibers, and we're allowing them the proper stimulus in the rehab setting to actually make improvements. So just getting somebody on a treadmill and walking is enough for some of these clients. So it's really exciting, super cool. But yeah, I mean, when I tell people like, BFR, or I hear people say, oh, BFR is just a fad, I kind of laugh and I chuckle, because that just tells me that they're ignorant right now about either they're ignorant in general, or they're just unaware of the vast amount of research that has been conducted thus far on BFR. And now it's only going to get even better with more and more clinical populations being investigated.
Absolutely, I can imagine so. Just bringing it back to getting people onto the treadmill. Now, I'm assuming you mentioned earlier on with regards to the cuff that these are people that you've built up to being able to tolerate multi-joint exercises, and then you whack the BFR cuff on them and get them walking on the treadmill? Or are they not using the BFR cuff on the treadmill and using it during their rehab?
So the way that I frame BFR is through what I call the pillars of BFR. And what that is a systematic approach for layering on intensity with BFR, such that pillar 1 is all the passive applications. So that would be something like what we call a self-swelling protocol, which just means that you're pumping up and deflating, getting the body used to that feeling of, oh my gosh, a pump, right? But you're doing it without the added muscle activation. That's critical because that's well tolerated by everyone. So if you have a very deconditioned individual that you're worried about trying to get them exercising underneath the cuff, and you don't want them to suffer any sort of adverse events like excessive muscle soreness, which can occur if you just throw them onto a multi-joint exercise with BFR, for example, or take them to failure on an isolated bicep, tricep, et cetera, movement, that could happen. And such, you get them on pillar 1 for cell swelling, and then you can get them in pillar 2 with aerobic training. Now, aerobic training is a bridge between passive cell swelling with pillar 1 and resistance training on pillar 3, because aerobic training has less muscle activation than the resistance training pillar 3, such that if you have less muscle activation that's occurring, you have less or no metabolic accumulation, such that it's not a significant stress. Typically, the report that people feel is, oh man, I'm tired. I feel like after a 5-minute cycle, I've actually cycled about an hour and a half. So that it's not intolerable, which makes it a great way to progress from pillar 1 to pillar 3, which is the resistance training. Now, once you get to resistance training, that then has a significant ability to create excessive amounts of soreness in your client based on their level of acclimation to the stress of BFR, as well as other intangibles like their previous exercise history, psychosocial things. These are all things that you should be considering when you're trying to determine where you're going to start in the different pillars to get them to get them back to the activities that they love as quickly as possible. So sometimes it means I'm starting somebody off on a passive application. Sometimes it means I'm starting somebody up on a aerobic walking program. Sometimes it means I'm taking them right to BFR exercise with push-up, whatever it is. If there's somebody like a bodybuilder, like I work with some bodybuilders, I work with some high-level athletes that have been or currently are competing. So those individuals I'm not as worried about in in increasing their soreness acutely because they're going to tolerate that, but that's not everyone. So it's really important to understand what happens or what are the stressors in relationship to aerobic, resistance, and passive. And that passive application is pillar one. And that will give you a gateway into how you're going to prescribe BFR.
Okay. You've mentioned a lot about the increases in muscle strength, muscle size, and you mentioned there that pillar two about aerobic exercise. Do you see much in terms of aerobic capacity gains or endurance of the muscle?
Yeah, so we're seeing crazy amounts of VO2 max increases in a variety of different populations. So we have to remember that on a gross overview of aerobic capacity, right? It's how much oxygen we can actually take in, how much we can then pump out, and how much we can then utilize, right? So there's different components to that. BFR acts on the utilization component, especially when we're talking about low intensity BFR, low intensity aerobic training with BFR, such that we're not really challenging to the degree that we would with a regular exercise. We're not really challenging our central capacity. Right? Yes, we do have some changes in our respiration rate, in our heart rate, in our blood pressure, right, within safe means, but it's really challenging the local energy metabolism, the mitochondria at that level. So it's funny because we're seeing these adaptations in well-trained athletes. We're seeing them in very deconditioned individuals and everywhere in between. So it's funny because I view BFR as a bridge therapy or bridge modality from getting people back to from low intensity exercise to high intensity heavy exercise. But there are applications that you can use BFR in the healthy individual to help accelerate their performance and recovery, whatever their goals may be. So yeah, I mean, like there's definitely VO2 max changes that do happen, and they're investigating some of the genetic transcription markers right now, PGC1 alpha, and some of the other molecular markers that are underlying the genes that are going to code for increases in mitochondrial biogenesis, increases in efficiency, and all those others. So this is a hot area of research right now, and it's only going to get hotter because it works and it's changing lives. So.
Okay, perfect. You mentioned there about using it on athletes as well in sort of general pop people that are competing. How would you add it into their training? Because I imagine normally they're going to be working at, let's take a bodybuilder, for example, they're going to be working at much higher rates of exertion. They're going to be taking it to, a different.
So it's funny you mentioned bodybuilder because that was the paper that I just wrote. I wrote a paper on the implication or the applications of blood flow restriction in the competitive physique athlete, both resistance training and aerobic training. So I don't want to talk too much about that paper, but that is something that's up and coming and it should be published hopefully this year. So there's a lot of good stuff that's going to be in that paper.
Okay, we'll get you back after to touch on it.
But in general, what you can use is when you acclimate to the stress, it generally is free volume. Especially if you're not working to fatigue or failure is what it means. As soon as you work to failure, that does have the potential to increase your recovery time. But generally speaking, the evidence that we do have suggests that combination of the high intensity exercise that's common in healthy individuals that are exercising without any impairments, and the addition of BFR to that plan is superior to heavy lifting alone and BFR lifting alone, such that there is a combined effect that's positive inside of a program like that. So typically, you don't need to apply BFR more than 2 to 3 times a week, although there are studies that do show high frequency application in healthy individuals could spark additional increases in muscle hypertrophy, muscle strength, along with some of the other factors that people spend way too much time talking about, but I don't think are super relevant, like satellite cell proliferation, excessive growth hormone release, systemic effects of BFR, These are all tend to be methodological limitations that are a result of most likely proximity to failure and not necessarily a novelty to BFR. But again, you are using BFR to accelerate fatigue. So, I mean, I guess I could see in some situations how people could view that as a potential mechanism of BFR. But me, I'm just not quite sold on those. But that's generally what you would use it for in the healthy population, is added volume without increasing recovery time. Decreasing the amount of time spent on cardio if you're trying to improve your VO2 max, increase your aerobic capacity, or even in pillar 4, which is return to sport applications that I speak about on occasion. You can combine it with high intensity interval work. You can combine it with like that end stage of rehab where you're really trying to you're clearing your ACL athlete to return to sport. You want to see how they look like in that fourth quarter of a basketball game, how they look like in that last couple of minutes of a soccer football game. It really because it does elicit an acute, profound fatiguing effect. So there's applications for that as well. But generally speaking, it's just you can use it as some free volume at the end of a resistance training session, as long as you're not taking it to absolute fatigue, or you can use it as a deload week when you're really just trying to reduce the stress on the joints.
Okay. And how much would you say that the addition of BFR has influenced your practice as a physiotherapist or physical therapist?
I mean, it's definitely a tool that allows me to accelerate their performance and recovery. I mean, like it's getting them back to the activities that they love quicker than what I've been using before. I mean, I'm a predominant McKenzie therapist, so I'm pretty hands off. I've been a personal trainer since 2011, so I'm very exercise based. So BFR fits nicely within my own biases, which is always important to recognize. That such that it's not something that I wouldn't consider, or something that's so far fetched or out of my own previous practice patterns that nothing has really changed. So it fits really nicely because it's a tool that I can use to accelerate fatigue and get individuals a training effect without having to stress their joints, for example. So it's been money in individuals recovering from back pain that are hesitant to have that axial and compressive loads and shearing loads really through the spine when they're getting back to squatting, deadlifting, whatever. So I can then regress them, practice the patterns, but then have them with BFR to reduce the absolute load that's going through the spine, and instead allow them to get that exercise, get those endogenous opioids going, feeling good about themselves, getting them getting active in the process, and again, away from those passive modalities that are so common in the rehab world.
Okay. And so how would you recommend for somebody to get themselves involved in BFR, be it as a new grad or currently practicing physio, to get their feet wet with BFR?
I would go take a workshop, whether or not you take my workshop, you take any of the other workshops that are out there. Just get trained, because all it takes is one clown to inappropriately apply BFR and something happens, and then we're all set back for years, because BFR has the worst name, blood flow restriction. So we're already starting off on a bad foot, but I think that with proper training, it is a no-brainer and something that you should seriously consider adding into your practice.
Okay, brilliant. And what about if anyone wanted to get in touch with yourself, if they wanted to ask you any questions or get you involved in anything? How can someone
So there's two different ways they can get in contact with me. The first one is through my Instagram. I pretty much have, I have the most comprehensive BFR Instagram on the internet. I have well over 300 posts on BFR, everything from what is BFR, why would you use it, how would you use it, implementation, everything. So I would definitely recommend to check that out. It's just the HPM, so the Human Performance Mechanic, the HPM, and then also with my BFR Pros, so the BFR Pros on Instagram as well, to keep up with everything that we're doing there. And then obviously my email is just nick@the BFR Pros, so they can ask me any questions. I get asked questions all the time. And then we have a Facebook group, the BFR Pros Accelerated Performance and Recovery, where there's so many clinicians, is over 1,500 clinicians from across the world, that we're able to have a discussion on BFR and talk about experiences and bounce ideas off of. So it's a very collaborative place. And so everyone listening who is welcome to apply to the group and get learned.
Nice. And have you got any, you mentioned, I think before we hit record, that you're going to be going to the NSCA conference in July, I think it was. Mm-hmm. Have you got any other upcoming seminars or conferences that you're going to be at? People can catch
Yeah. So, I mean, I think just for this year, the only one that that's left is the NSCA conference. There may be some other conferences that people have asked me to. They haven't been officially scheduled, so I don't want to talk about it. But the one in July, I'm going to be talking about blood flow restriction and fatigue. So it's going to be a pretty cool talk, and I'm very much looking forward to it. I think it's going to be raise some eyebrows and get people interested in the topic. And then hopefully, I have a couple more international workshops with Kinesport scheduled in France in April, as well as I'll be in Italy with Nova Via and in March, and I think maybe June or something like that. So just check me out there if you're in the United States. I'm going to be in Florida in May and December, and Oregon in March. And those are the only real public workshops that I'm giving this year because I'm pretty tied up on the private side. Yep. So that's it. Yeah.
Okay. Lovely. Perfect. Thank you very much for your time and being able to come and speak to us today.
Thank you. Appreciate it.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time.